Hi, I'm Brad Power, and this is the Cancer Patient Lab. And this is our weekly webinar series. Today, we're honored to have with us Karen Merritt. Karen is a patient advocate. She'll tell her story. She was a caregiver and experienced a unfortunate toxicity reaction of a loved one that could have been caught with a diagnostic. And what she'll talk about is both that story, but also how it's a challenge to get a new diagnostic into the standard of care. Before we get started, we have a standard set of housekeeping things, which I'll quickly cover. First of all, this is for information only. It is not medical advice. We try to arm our patients and caregivers with information they can take to their medical team about ways to improve their care. Second, this is all going to be made public. So if you're concerned about having your image or your name or anything you say shared publicly, you can turn off your camera, change your name, and don't say anything. And then finally, we are a 501c3 nonprofit, and we welcome donations from anyone who is inspired by the services that we're providing to patients and caregivers. And with that, I'll turn it over to Karen.
Wonderful. Thank you so much for having me, Brad, and the Cancer Patient Lab. And through the introduction, it's so nice to see cancer survivors, and kudos to you all and those still fighting. So getting a better diagnostic into the standard of care. So this goes for all diagnostics, but specifically my advocacy has been around DPYD. So what is DPYD? Well, this is a gene, and it's the dihydropyrimidine dehydrogenase gene that tells your body to make the DPD enzyme. The DPD enzyme is needed to break down fluorouracil and capecitabine from your body, and then it excretes the excess. So genetic variants in the DPYD gene can lead to not enough enzyme function or no enzyme function, depending on which variant. And those with reduced or absent DPD enzyme, which we call DPD deficiency, are at risk of potentially life-threatening fluorouracil overdose because they're having severe toxicity and could also lead to death. So this is my mom, Linda, diagnosed in 2014 with stage 3 anal cancer, 73, otherwise healthy and enjoying retirement. Her treatment plan after a routine colonoscopy, it was 5-FU chemotherapy with radiation. So chemoradiation. Her oncologist said this was fairly well tolerated. So this is what happened to her without this pharmacogenomics test for DPYD or pre-screening and not being informed about the risks of DPD deficiency. She started on her first infusion on June 9th, a 46-hour drip, and she had been a registered nurse. So by that Friday, she called her oncologist because she knew she was dehydrated from the continual diarrhea, the neutropenia, and the mucositis. So the sores that were beginning in her mouth all the way down her digestive tract to her anus. So after she returned home from hydration, and in the ER, there was no conversation about her mouth sores or that this could be a toxic reaction. A couple days later, she falls getting up in the middle of the night to go to the bathroom. And at this time, she's not eating or drinking anything because it hurts so badly. Swallowing anything is like razor blades. She falls, she goes to the hospital, she's in ICU, she has round-the-clock care. We are told by the oncologist on call from her practice that there's no way to have known this could have been her reaction before treatment. With what we know now, that's incorrect. She could have had a DPYD test done before treatment started to figure out if she had enough of that DPD enzyme. They told us she was very sick. She'd be in the hospital for a few weeks. She died on July 2nd, 2014. And unfortunately, her death certificate lists cardiac arrest because as part of the toxicity to 5-FU and capecitabine, you end up with multi-organ failure. We should have fought to change that death certificate to make adverse drug event to toxicity to 5-FU be the #1 cause of death, so that this would have been reported through to the FDA and MedWatch as an adverse drug event. How often does this happen? Well, it used to be a risk considered rare and acceptable in the NCCN and treatment guidelines. They are changing that. 3 to 8% of the population have a DPYD variant. We are using about 1 in 20 people are DPD deficient. Variant carriers, as I've said, have a chance of severe toxicity and 3% chance of death. This is estimated to be over 1,000 deaths per year in the United States, as in the National Libraries of Medicine, from a study written by a doctor, the last name is Innocente. 1,000 deaths a year. That's like 3 jumbo jets. If this was the FAA, they would ground the planes until they resolved the issue. Most people are unaware of the deficiency until it's too late. In 2015, there was a supposed antidote, and I say supposed, Vistagard has to be administered within 96 hours of the last dose or the end of the infusion. But oftentimes the toxicity is not diagnosed. It's very complicated until after that window is passed. Also, Vistagard is about $80,000 and also needs prior authorization, which can also be very tricky when you're working with a time constraint. Pre-screening for DPD deficiency and dose adjustment based on CPIC, which is the Clinical Pharmacogenomics Implementation Consortium. And I believe after watching and listening to Christine Ashcraft's presentation or sharing with Cancer Patient Lab, she talked a lot about the highways that drugs go through, and that CPIC gives guidance for DPYD as well as some other medications. So this is my mom in the middle. We like to say she was so easy to live with and so hard to live without. Our mission as a nonprofit is improve the standard of care for cancer patients undergoing 5-FU and capecitabine chemotherapy to include DPYD testing. We became a nonprofit in 2022 after these families came together, and the human cost of not testing is actually what brought us together. Single treatment, fluoropyrimidine chemotherapy, no pre-screening, no information about the risks of DPD deficiency, severe adverse reaction. The suffering is horrific with the sores from your mouth to your anus. With capecitabine, patients end up with scabs on the outside of their body. They actually look like a burn victim. These are other nonprofits who have written letters of support for pre-treatment DPYD testing. Well, where does this stand in the United States? The president of our nonprofit, Ken Serpinot, learned that you can write a citizen petition to the FDA to revise drug labels. So in 2016, he did just that, and they dropped the word rare from the drug label. He then wrote another citizen petition in 2020 with the help of our medical advisors, and they answered the citizen petition for capecitabine in 2022. And in the labeling then, the information was that now clinicians need to share the risks if you're DPD deficient and discuss testing. They did not recommend testing, which is what we want to happen. And 5-FU was changed in March of last year. The FDA realized there was a problem. They hosted a DPD workshop January of this year where I was able to share, and other advocates from our group came and were able to ask questions. And what they learned from that meeting is clinicians were not aware of the drug label changes for capecitabine and 5-FU. So they issued an FDA safety announcement on January 24th of 2025. this safety announcement has met with a lot of embracing of, wow, we need to make sure our clinicians know about this. And I, as a clinician, need to make sure the clinicians are saying, I need to tell my patients. It's not 100% of clinicians, but we're seeing more being aware. They're paying attention to what they're hearing. We've been trying to challenge the status quo of the NCCN and ASCO guidelines by change the standard of care. You can submit guidelines requests to each NCCN panel. You need to submit them on their website a month before their meeting, and you can go on the NCCN website and find out when each cancer panel is meeting. ASCO has one submission you can send in, and we have done that as well. Europe is paving the way in DPD deficiency testing. It's has been recommended since 2020. Now, I'm so excited to share that just Monday, the last day of colorectal cancer awareness month, the NCCN updated the colon, anal, rectal, and small bowel cancer guidelines. So that they had in those guidelines a comment of, we do not recommend testing for DPD. They took that out and replaced it with this sentence of testing for DPYD genetic variants should be considered prior is big, to fluoropyrimidine therapy. After discussions regarding risk assessment, patients may choose DPYD genetic testing. They go on to say that there's no specific test recommended and that there's insufficient data. Well, we as advocates disagree with the insufficient data to inform dose adjustments because, as I mentioned before, we have the Clinical Pharmacogenomics Implementation Consortium. So why is this guideline change important? Well, first of all, patient safety. Secondly, insurance coverage. Insurance companies will follow NCCN guidelines. And often what we've heard is clinicians don't want to talk about another test with a patient, even if the test is only, well, I say only between $300 and $500, but they don't want to add more financial burden on patients. Another wonderful thing I found out just recently is Fight CRC, so Fight Colorectal Cancer, in their care sequences, they're calling out DPYD testing. We hope to see other cancer organizations follow CRC's lead for safer cancer care. Because this one I understand is only for colorectal cancer, and we're talking at Cancer Patient Lab about all cancers. So this is an example of the care sequence, and this is in combination with a company called 4R Oncology. I'm not sure if you've heard of that, but they have done some studies at cancer centers. So it's the number 4, the letter R, and oncology. And this is part of what they are providing or helping is doing these care sequences. And if you go on here for CRC systemic, they have chemotherapy before surgery and then chemotherapy for after surgery. And they're both calling out testing for DPD deficiency. On our website, we are compiling a list of leaders in testing. This has been super effective for patients when they go in and talk to their provider and say, I want a DPYD test. Institutions on the left, they test all their patients, unless there's an opt-out for something or because chemo has to start on Monday because it's super advanced disease. The other list is institutions or clinics where OneOncology practices testing. For instance, University of Michigan, all breast cancer patients are tested for DPD deficiency. It's, to me, as a patient advocate and knowing what can happen with this chemo, I don't know why they wouldn't just test all patients. And part of it is systems flow. The hospitals need to make it easy for the providers. Just include it in their initial patient workup so they don't have to do something, another box they have to check or something else that they have to remember when they're talking to their patient. So this is my call to action when I'm usually sharing outside to people. Most of you are patients or in labs. Lab companies can have a DPYD panel to include all of the Association for Molecular Pathology DPYD genotype recommendations. The Association for Molecular Pathology is trying to standardize labs, so they came out with a DPYD recommendation in August of 2024, and they have two tiers for DPYD variants. Tier 1, must have. Labs should all have these variants, and Tier 2 would be nice to have. Now, when at the FDA workshop, there was a oncologist there from Mayo Clinic in Arizona, and she usually uses the 8 variant DPYD panel from Mayo Clinic. But after this AMP guideline came out, she now uses the Mayo Clinic full DPYD gene test because the 8 variant panel at Mayo Clinic does not include all of AMP's Tier 1 recommended. So pharmacogenomics in cancer care, that's exactly what DPYD is. It's a pharmacogenomic test. The FDA has a table of pharmacogenomic associations. You can go on there and look at the drug name and find out if there's if you don't see the drug there, it doesn't have an association. So they list all the associations and they'll tell you what the drug is, what the gene is, and then what the disclaimer is or why this would be important. So for DPYD, or for fluorouracil and capecitabine, you can see the DPYD gene and that it's for poor and intermediate metabolizers. It can be have dire consequences. Irinotecan, and I don't know what the generic name is now. I'm thinking that that's the main name, but the gene for that is UGT1A1. And then there in cancer care, there are pain medications and anti-nausea medications. And it's important for us because we all are 90, I think it's 99.9% is what Christine says that we're the same, but that 0.1% that we're different changes how each of us are going to metabolize different medications. I mentioned the Clinical Pharmacogenomics Implementation Consortium, CPIC. They have guidelines for DPYD and UGT1A1. And then the American Cancer Society Cancer Action Network, they are trying to pass biomarker legislation in each state, which would expand insurance coverage for biomarker testing. And this is what pharmacogenomics is, right? The right drug for the right patient at the right dose. And thank you so much. This is my nonprofit, Advocates for Universal DPD, DPYD testing, co-founded with others. And I will stop sharing my screen. Thank you.
Thanks, Karen. Again, for everyone in the audience here, if you want to ask questions, you can do so by raising your hand or by submitting questions through the chat. Rick has already submitted a question there. I'll read those to you, Karen, so you don't have to be worrying about keeping track of all that. Just 2 quick questions I just want to do to set the stage. Is the DPYD test a blood test, or is it something they're doing off of your tissue biopsy?
It's a blood test, but they can also do a cheek swab.
Okay, so pretty low invasive in that domain of expense.
Yeah, the Veterans Administration, the way they have handled testing is they have added DPYD testing to the initial patient workup. So if you have a patient coming in and you know you're going to probably treat them with this medication, if you request that test, the test is requested at the same time as you're doing other scans. You could be getting that test back before some of your other results or biopsies. That used to be a reason that they didn't want to order this DPYD test is the time that it takes. But the test turnaround time is now 3 to 7 days or 3 to 10 days, depending on which lab you're using.
While you were talking, I looked it up, and 5FU or what's it called?
Fluorouracil?
Fluorouracil is, I guess, part of FOLFIRINOX, which is a common standard treatment for pancreatic cancer. You listed colorectal cancer and a number of other cancers, but I didn't see pancreatic cancer on your list. Is there a reason for that?
On our list of supporters?
Yeah, no, on your list of cancers that you're trying to get it in the NCCN guidelines for.
Oh, no, that list, we're trying to get it. We want any patient that's going to be treated with this medicine. That is just the guidelines that changed their guideline. That is just the panels that changed their guidelines.
Okay,
So, hepatobiliary, which I think is bile duct cancer, um, breast cancer, yeah, any cancer that uses Folfox, FOLFIRINOX, Capox. I don't know what some of the other names. Any cancer, any treatment that's going to use fluorouracil or capecitabine, DPYD testing should be done prior to treatment.
thanks. Yeah, we have. I just thought of it because we have three pancreatic cancer uh, patients in our audience. Mike, did you have something you wanted to ask?
Yes, irinotecan is also a part of FOLFIRINOX. So
Oh,
Oh,
I think we should all be aware that there's another gene that you put on your slide. Uh,
yes.
yes, so that's important for patients with cancer to talk with their oncologist as well.
Yes, UGT1A1 is that other gene.
mm, okay.
I
Well,
have a question, another question. How do oncologists or pharmacists know where do they go to find out how to adjust the dose of the drugs that are affected by the genes?
The Clinical Pharmacogenomics Implementation Consortium,
Yeah,
CPIC.
they go there.
Yes, they have dosing guidelines. So the Association for Molecular Pathology that I think I shared with you, they give guidance to labs on which variants have the most evidence or the best evidence that this could be toxic. And then CPIC is actually gives the dosing recommendations.
That's great. Because I would think that one of the reasons why they don't order it is because they may not know what to do with the results. So that would be very
It's
important.
one, I don't know. I think a lot of labs, like for me, I had um, my DPYD gene test because this is hereditary, right? I inherited this deficiency from my mom. I had my DPYD test done through two places, Mayo Clinic. And when they sent my results back, it told me on there, this patient, should they receive fluoropyrimidine chemotherapy, should have a reduced dose. And they give you a metabolizer status of 0 to 2, 2 being full function DPYD gene, and then 1.5, 1, or 0. I'm a 1.0, so 50% dose is what my report shows. Um, I don't know if you guys have been hearing about color health lately in the news. I agree, David. I also got a color health test to test for some hereditary cancers, and their pharmacogenomics panel is really amazing. I mean, that opened my eyes up to some other medications that I've taken, like I can't take Prilosec, but Nexium would work for me if I had heartburn, and it's just based on the different drug and the way I process it. So I had all my children tested through color because it was easy. I They sign up for it, they mail the tube, they spit it in it, zip it back up, and send it back to color. In a couple weeks, 2 to 3 weeks, they sent the result back. And I'm happy to say none of my kids inherited the DPD deficiency from me. The president of our nonprofit, whose wife died 2 years prior to my mom, identical story, Catherine, their four children all inherited DPD deficiency from her. So it used to be on the patient to tell the clinician that I have this, but with the labeling changes from the FDA, it's the clinician now needs to make sure they're discussing DPD deficiency with patients and talking about testing. And the same would be for UGT1A1.
Okay, let me read one of the questions from the chat from Rick Davis. Is DPYD a risk for gemcitabine use?
I am not an oncologist. I don't think so. We have a patient who was on capecitabine, and is gemcitabine Gemzar? I think so. No?
I don't know.
So
Yes, it is. Gemcitabine is Gemza.
okay, so she got a DPYD test, and our medical advisor is one of them is Dr. Gabriel Brooks out of Dartmouth Hitchcock, and he would have brought that up or let us know. So I don't believe so, but it would be a good question for an oncologist or a pharmacist.
Okay, Cindy has her hand raised.
Yes. Hi there.
Hi.
Two questions. Is there any kind of clearinghouse or list of genetic, tendencies toward bad reactions for chemotherapy drugs? It seems like there should be some clearinghouse that's available in terms of just advocating for our patients, where we could say, okay, so-and-so, you have pancreatic cancer, these are the ones you want to look for. So-and-so, you have marginal cell lymphoma, these are the ones you want to look for, and not just depend upon standard of care, oncology departments, so forth, offering this up. That's one thing maybe you could speak to. And then the other thing is, have any institutions, to your knowledge, been sued as a result of not, informing a patient and then there being deleterious effects? And I ask this because very unfortunately, that is often what moves the needle to change, best practices, so-called best practices.
Yes, great question, Cindy. A clearinghouse, that would be a great resource for cancer patients, I think. The only way I think that right now people can find that out would be going to that FDA table of pharmacogenetics associations and looking at the medicine. And it's very unfortunate that it's great that science is moving so fast, but I don't think that some of the science that's happening, our oncologists they've been practicing for some of them for 30 years and maybe aren't as up or aware about the science that is out there. And it does take, as we're seeing, a long time to get it into practice. And that's why we've put in submissions, or we call them petitions, to the NCCN to change guidelines, because we want more clinicians to be aware. And even if it's in the labeling, if it's not in the guidelines, they're really, one oncologist said, as a community oncologist, I'm married to the NCCN guidelines, and so is insurance coverage. And the second question, lawsuits. Thank you for bringing that up. There was a lawsuit filed in 2019 against by a widow, Oregon Health Sciences University. And this was before the labeling changes, but they were successful. Well, they settled that lawsuit 2 days before going to trial. The lawsuit was for $6 million. The settlement was $1 million. And it was all for lack of informed consent. They did not tell the patient. And this man had bile duct cancer. He had a Whipple surgery. And from what I understand, that's a really complex surgery. He recovered from that beautifully. And this was, the surgeon said, you're cured, you have no cancer, go enjoy your life. Then he went and met with his medical oncologist, who wanted to do cleanup chemo, is what she says. And capecitabine, by day 7, things weren't going well. And just like my mom, once he went into the hospital, he never came home. And it's like torture.
Do you think of suing with your mom, or is there a statute of limitations? Because it sounds like there really needs to be more lawsuits. To
Yes,
make
there do need to be more lawsuits. We did think of it. We should have in hindsight, especially with the note in my mom's chart that said there was no way to know of this before she died. There are lawsuits going on. It's just the legal system, like the medical system, it takes time. There are some individuals in different states looking for attorneys, because we have an attorney that we know in Washington State that has a case that will go to trial in February of 2026. 42-year-old man, 6-month-old son, very capecitabine for colon cancer, very sad. And a couple other cases in different states. We had a patient that reached out to us from our website, and so this is also a stage 1 bile duct cancer. She had a second opinion, and she also had at a NCCN member institution, and she also had a community oncologist. She asked them for a DPYD test because she had read about it and she saw our website, and they both told her, oh, we don't do that testing in the United States. And she said, look at this list right here. Yes, we do. So she pushed. They finally conceded to her request. She got the test. She has the most common variant. She needs a 50% dose reduction, and she called to let us know that if she hadn't been tested, she and her husband and kids know, or they feel that she would have died.
Sounds like you need a class action suit.
Yeah, what we've been told is we need to get we need to get some wins before we can go to like that big battle, right? We need to win a few little wars before the big one. But it takes time, and unfortunately, 1,000 patients dying every year. That's like 10,000 patients since my mom passed in 2014 alone. I think you're muted, Brad.
Next question from the chat, Bill Passman. How much has the cost changed for the DPD chest over time?
Oh, significantly. I mean, in 2014 for my mom, it was probably going to be, if they had tested $1,000. You can get it through some lab companies for $200. And one of the lab companies I know, I was just at a conference that they were there also, One they have, their test is $199. And they have if you can't pay that, they have a patient assistance program. Mayo Clinic, their 8 variant panel is $285. Full gene at Mayo Clinic, $585. And then I mentioned earlier color genomics. When I had that done, my last child had that done last year, was $288, and that wasn't just for DPYD.
Yeah, that patient assistance program is an interesting avenue. Brian, we were talking about how you get access to drugs. We should check into that because, you get the price for some of these treatments is very high. And then the insurance company maybe denies it. But if you go to the manufacturer, they might have a way around that. So it's worth checking.
Yeah, it's great to ask, call those companies. I was just talking to somebody else, and they, this was it wasn't cancer, but she had this huge expense, and she's like, these drug companies want the drugs to stay out there, right? So she called the drug company, and they're paying her copay. She couldn't afford the copay. The drug company is going to pay her copay.
Next question from Dennis Watson. Is the test included in any of the broad germline hereditary panels from companies like Myriad?
I don't know about Myriad. I do know that Tempus has a panel where they are testing your tumor, I believe, but you can do an add-on for DPYD. I'm trying to get Tempus to, if they're testing you for your tumor, why not just include DPYD and UGT1A1?
Okay. David Plunkett's question is like, David, since you're here, do you want to ask?
May I just follow up on that, Brad?
Sure.
excuse me for butting in, because I'm actually looking at the colored panels right now. And not all the color panels include DPYD. So just because you had a color test doesn't necessarily mean you tested for it.
Yes, you have to have their extended panel.
Right. I just wanted to point that out to everybody because I just got a color test and I didn't see anything about that. So
And if that's the case, Rick, I would call them and ask them, as it's my understanding, sometimes when they get something for, like a test from somebody, they're gonna, or a sample, they're gonna test it all because that's what they do on their panel, but they're only gonna report out to you on what you requested. So I would call back and ask.
I would. This was part of a large clinical trial called Promise for people who have prostate cancer, and I suspect they just use a very basic thing for the trial. But that's a very good suggestion. But I just want to be sure people think just because they got a color test, they got tested. That may not be the case.
I appreciate you saying that, and I should remember to say the expanded test, but I would call, if you were in that trial, I would call and ask. They have that information.
I will. Thank you.
David.
Yeah. So DPD deficiency is something entirely new to me. So my question is, are there consequences to it other than this intolerance for certain chemotherapies?
There is I don't know what the term is. So most people with DPD deficiency have no outward signs. There is one type of DPD deficiency that's super rare that you do have signs as a youth. And I am not educated on that at all.
Well, should anything prompt a request for the test other than upcoming chemotherapy?
I don't believe so. Not for an adult. I think the other form of DPD deficiency would be evident as a young child.
Okay. Next question from Dennis Watson in the chat. Do patients with this have different response rates? I.e., if you have to lower the dose to reduce adverse events, does that mean lower response rates and outcomes? If so, it would seem trying an alternate drug path may be more valuable than a reduced dose of the frontline drug.
That is one of the concerns of the NCCN and why they have said they won't reduce the dose. But first off, there are studies that show that it does not reduce the efficacy by reducing the dose. And like Christine Ashcraft shared with this group, if you are for instance, my metabolizer status is like 1.0. So I have a half functioning DPYD gene. So that means that my body can only process half the dose. So in effect, I am getting the full dose for my genes. And our response to NCCN when they say reducing the dose might not cure the cancer. Well, in the case of most of the loved ones in our group, there is no curing the cancer if you've killed the patient because they have an overdose of 5-FU or capecitabine.
Yeah, we've had conversations about minimum effective dose and maximum tolerated dose, and most of the drugs have been approved at a level of maximum tolerated dose, and then that's the way they go into the guidelines. And so the notion of personalized dosing is a reasonable thought process that people could be getting the minimum effective dose personalized based on their metabolization of that drug.
It seems like clinical trials too for new drugs they're having to include or look for lowest effective dose, right? And pharmacogenomics, personalized precision medicine.
I know Chris Apfel has put a couple things in the chat. Maybe Chris, you could also comment on this, because I know that when he's running his functional tests, they also do them at different dose levels. So Chris, what are your thoughts on this? You're on mute. Or something. Or maybe your microphone's not working.
Okay, you should be able to hear me.
There you
hear me
go.
now?
Yeah.
Okay, great. So first of all, I'm very saddened to hear about the loss of your mother. When I listened to that, it made me really, really angry. And in particular, because this is known. Every oncologist knows that. And so the fact that this was for a long time not in the guidelines actually shows that there are other aspects than patient safety that play a role how oncology practice is practiced in reality, which are health economic considerations. And I think that's behind it. There are a few other mutations as well, actually variants, polymorphisms. I've put a little table in there, but the one that you are hitting on is by far or clearly the most important one, or the most frequent one with fatal outcomes. In regards to the dose adjustments, the effectiveness on a tumor is clearly dependent on the dosage that the tumor gets. And if we think about metabolism, and you are low metabolizers, and therefore with, let's say, a third of the dose, you still have twice the concentration in the blood. If you would reduce the dose to a level that you actually have effective blood concentrations, there's no reason to make the argument it would be less effective. I actually think it's pretty clear cut. And if we are doing our functional profiling, we can actually see which tumor is responding to which drug. And we can actually see dose response curves that are often fairly flat. And it means, what I mean with that is sometimes you need an order of magnitude difference to get from 70% kill to 90% kill. And it's tenfold difference in drug dosage. So you should always consider the toxicology, and the argument that this would be less effective is a very weak argument, and especially when you're a slow metabolizer, because if you only metabolize at 1/5, let's say 1/5 of the speed, and you give 1/5 of the dose, you still have the full effective plasma concentration for which the clinical trials were designed. So that argument, dose adjustments would make it less effective, that's scientifically not right. Sorry.
Right.
So I have two things, Doctor. Thank you for that. I'm looking at your chart of PGI or DPYD. So how many variants is that? Is that 4?
You're on mute, Chris. Chris, you're on mute.
Yes, I listed 3, but those are just examples, right? So what I listed here are 4 of them, but there are some more. There is a CYP2D6, which is a very common one. There is this argument about tamoxifen, for example. That's one part. There are a few others. They're not as common and also a little bit more controversial. But CYP2D6, which I didn't list on that table, I believe, that's another one that also could easily be tested for.
Yes. And when the NCCN just updated those guidelines, they said that there's no concrete evidence on how to reduce dose, which as an advocate, I disagree. I think those CPIC guidelines would be great for dose adjustment. And that's exactly what the institutions that have implemented testing, they are using CPIC. And I believe CPIC has guidelines for CYP2D6 as well, CYPD. So
Could so the argument there is no evidence is really I hear this very often, and what this is actually, it's in different form to say there are no prospective randomized control trials with 5 million patients that have actually shown that it makes a 1% difference.
Right.
And evidence is not a binary parameter, right? There are different levels of evidence. If you look at the Bradford Hill criteria, there are 8 criteria for level of evidence, or for what is what distinguishes a correlation with causality, or what makes a causality likely. And there are many arguments for it. There is a lot of evidence for that. What they often say is, well, there aren't sufficient prospective clinical trials for that particular individual case, and then to really to prove it, to find the ultimate proof. But the evidence is there. There's no question on that. So they should not be. I think one should push back on that, and I'm happy to help you and communicate with you offline. I think this is outrageous, and one really needs to do something about it.
Yes, thank you. I woke up in the middle, I was awake in the middle of the night trying to figure out, oh my gosh, I thought that this year going to ASCO annual meeting, we would be celebrating change of guidelines, but yet I wake up in the middle of the night figuring, how can we use this patient who got her testing and was DPD deficient? And then I read, you can't use case reports as an abstract at ASCO.
Yes.
So.
Okay, Roger's raised his hand.
Okay, hello, thanks. This might be a little off topic, but it kind of reminds me. So by the way, so I was at Stanford. I had all of the chemo drugs you mentioned and some more. And I do believe I had that test because I remember at the start, as a patient, I'm on a need to know basis. And I guess I didn't need to know what tests they were running, but they told me I was okay to take the chemo. So I think that institution uses it. But, there's so much more they don't tell you about chemotherapy drugs than they do. And I'm hearing a lot more about metronomic dosing, or this what you're saying, minimum effective dosing of chemo, and maybe spreading it out over a longer period of time. Because I got the maximum tolerable dose and then some. And what I'm starting to worry about now is what I've learned now, that because they gave me a long list of side effects. It was like 2 pages long, and I had all of them. But they didn't tell me everything. And I understand now there's quite a bit of evidence that the chemotherapies that I had, almost every one of them, results in probably a 10-fold increase in leukemia risk. And I don't know if I'd have done the same thing if I'd have known that then. And this is sort of the tip of the iceberg of things that patients don't know and are not informed about and don't really have much of a say in, because we just don't get the information. And I really feel like it's standard of care, and I think it almost starts with FDA guidance. I think you're on the right track on that. This might sound odd for an attorney to say, but I'm not sure litigation is the right way to get there in this case, because it's hard to sue a doctor. You just look at the way, some of the things they do. On the other hand, every one of them knows about, what standard of care is and what the FDA has approved, and, what your insurance is going to cover. In fact, a lot of times I feel like the insurance company was deciding what treatment I get more than anybody else. So I feel like that's probably the right path. So like I say, it's a little off topic, but if you got any comments on that, I'd love to hear them.
Yeah, I just went to this interesting and very unique cancer conference in Louisiana. So in Louisiana, they have the Cancer Advocacy Group of Louisiana. They call it CAGLA. It's a nonprofit to make cancer care better in the Gulf South, mainly the state of Louisiana. And at one of the exhibit booths, a drug company, they told me about the SALTZ regimen, SALTZ. It's a doctor. I believe he's at Memorial Sloan Kettering. I asked the guy, is he still practicing? He said, I don't think so. Well, I think he still is. And it was like, I think the regimen that he does, and I read about it just yesterday, for healthy patients or patients other than their cancer, right, that are strong. I think it's the FOLFIRINOX. He just like gives them a really strong dose all up, because that's 5-FU, irinotecan, oxaliplatin, and
Yep.
leucovorin, I think. And I can't find the research, but a lot of patients did not do well in that regimen because you're right, you're giving so much. Why not have reduced dose over a longer period of time so that you actually want to stick with your treatment too, right? Like if you're not testing patients or you're giving them too much for them and then they don't want to stay on their treatment because that was so horrific, all right? But if you could give them a lower effective dose over a long period of time,
Right.
and Richard Pazder, the director of the Oncology Center of Excellence, he had a paper out in 2020 about when less is more when it comes to chemotherapy.
Mhm. You know, I kind of think it's an economic issue because I've been thinking about this a lot over the last 3 years. And I know when I walked into that chemo room, they were packed, they were oversubscribed, and I was only there 1 day a week, like everybody else. If I had to go back every day and, get a smaller dose, but every day, there's no way that facility could have handled that many patients. So I almost kind of think that maybe that's the reason, that's the protocol, but that's just my cynical mind at work, I guess.
I think what I've heard too is that's why a lot of people would prefer capecitabine, an oral pill where they could take it at home versus in an infusion center like that. But there are complications with that too. Like you have to be well hydrated. You need to, drink it with something that isn't gonna automatically inflame your esophagus. And yeah, it definitely seems like patient safety and patients and families are demanding this now, right? Like how can we want to cure the cancer, but we want to make sure that the patient has quality of life and will stay on the treatment and is safe.
No, I think you're
Thank you.
on. I think you're onto something big there, which is I've seen is that the first thing was like make sure the patient lives, and then the second one was actually the treatments are getting good enough, and then people are having a long life and living with the side effects of the drugs that they took. So let's look at those. Could we swap out a more toxic drug for a less toxic drug? And we just had a session, which I should plug. You can see the notes in the learning sessions with Javed Moslehi, who was looking at a number of chemotherapies and their effect on the heart and downstream heart and cardiovascular issues. So that's kind of emerging as a more common topic where keeping the patient alive was the first thing, but now it's more, it's a chronic disease. Now, how do we have a good quality of life living with the treatments that we're getting? So we're about the top of the hour. Karen, Rick has a question or comment.
Yeah.
Rick?
Well, this raises an idea for another session, Brad, which is to talk about dosage and toxicities. We right now are about to go to a pharmaceutical company that we work with who has a phase 1, phase 2 trial in process for a radionuclide. And the benefit of this radionuclide is you can deliver treatment in 2 weeks rather than 36 weeks, which makes a huge difference for a patient. Problem is when you look at the toxicities, they're much, much greater. So the question then is, well, is there some spot between 2 weeks and 36 weeks where there is a benefit? However, maybe we can go a little bit longer and we don't have so many AEs. And so it's right on point. And as soon as I hang up, I'm going to talk to one of my doctor advisory board members and figure out how we go back. So just a thought, but I think this happens in a lot of places. Karen, looks like you want to say something on that.
Oh no, I was just shaking my head, and You know, sometimes I meet oncologists and they're not a fan of testing. Well, this one doctor's he said I'm retiring next year, but I would never start a patient on full dose 5-FU. I start them at 50% dose and I give them my mobile number and I say, if your symptoms are any worse than this, and this,
Yeah.
call me, something's wrong, right? But that's not the oncologist that's just starting to practice on their own and is looking for the recipe book of the NCCN guidelines, right? So he just kind of, and he was a community oncologist here in the state of Washington in a small town, but it's nuanced, but patients need to be made aware. And yes, I agree. Like, how can we get less toxicity? But I like the timing is probably better, but this woman I was telling you about, Emily, the patient who had to push back to get her testing, she's doing really well on the low dose. Like she's able to work and play with her kids. So that's
I
important.
think patients should always be prepared to go back to their oncologists and talk to them about lowering the dose and maybe increasing the frequency if they're having comorbidities and side effects. Patients don't feel empowered to do that.
Yes, that's important right there. Patient empowerment, because we trust our doctors, right? My mom, we wanted her to get a second opinion. She wouldn't hear of it. She was super comfortable and confident in her doctor. So, asking for more and empowering patients with information, right? Saying, no, look at all these places where they're doing this testing, whether it's DPYD, UGT 1A1. I think Dr. Chris Affel put in the chat there some other genes to be on the lookout for. And I've heard of them, but I don't, the TMPT and the NUT15. Very important for patients to be empowered, and we need to, what you are all doing in empowering patients is super, passing all this information along and sharing with, I mean, I look at the different people from different places just here on the screen. Very important. Thank you so much for what you guys are all doing, and ladies.
Thank you for watching.